Hi everybody, and welcome to our module on demyelinating disorders. You can divide demyelinating disorders up into those that affect central neurons and those that affect peripheral neurons. The major demyelinating disorder that affects central neurons is multiple sclerosis, which I talk about in another video, but there are a couple of others and we'll go through these in this video. In addition, we'll go through some disorders that affect peripheral nerves. Acute disseminated encephalomyelitis is also called post-infectious encephalomyelitis, and this is an inflammatory central demyelinating disorder that is common in children. Children who get this disorder have the acute onset of multifocal motor or sensory deficits. So what this means is they can have weakness that may involve an arm or a leg. The same thing is true for sensory defects. They won't just be in one area of the body, they can be in several areas. That's why it's called multifocal. In addition, children who get this disorder often develop confusion, that's from encephalopathy, and often it progresses very quickly so that children rapidly become very confused and require hospitalization. And the reason it's called post-infectious is because it classically follows an infection or sometimes a vaccination. It's usually a couple days or weeks after an infection or a vaccination. The mean is 26 days later. In terms of infections, it often follows varicella or measles. This is a child with chickenpox, which is varicella infection shown on the screen here. These infections are uncommon today because of immunizations, but before the era of immunizations, children who had measles or chickenpox often developed this disorder several weeks later. In terms of vaccines, it's been reported as following vaccination for rabies and smallpox in some patients. The main way you're going to recognize this condition in a board question is by the history. It's going to be a child who had some type of infection or vaccination a few weeks ago. If an MRI is done, it usually shows bilateral asymmetric lesions. Remember that this disorder causes multifocal neurologic problems, so there are going to be multiple different foci in the brain of lesions. And you can see an example of these lesions here. There's one here, there's one here. They're in different parts of the brain on different sides of the body. And the treatment is steroids. Usually the child is hospitalized and given intravenous methylprednisolone. Neuromyelitis optica is a rare disorder that mimics multiple sclerosis. Just like multiple sclerosis, it's an inflammatory central demyelinating disorder, and also just like multiple sclerosis, it can involve the optic nerve and the spinal cord. What's unique about this disorder is that it is associated with IgG antibodies against aquaporin 4. Aquaporin 4 is a water channel protein that's found in the spinal cord and the central nervous system, and the presence of these antibodies is the major factor that distinguishes neuromyelitis optica from multiple sclerosis. And the way you make a diagnosis of this disorder is by MRI findings, which we'll talk about in a minute, plus antibody tests for aquaporin 4. Neuromyelitis optica gets its name because it presents as optic neuritis plus additional symptoms. And this is similar to the way that multiple sclerosis can present. Multiple sclerosis often presents with optic neuritis. The additional symptoms include transverse myelitis, which is a spinal cord problem that leads to motor and sensory loss, and also brainstem syndromes with motor and sensory problems related to the cranial nerves. And all of these things, optic neuritis, transverse myelitis, and brainstem syndromes, can happen in multiple sclerosis, and I talk about them in greater detail in the video on MS. There is one way that neuromyelitis optica can present that is different from MS, and that's called an area postrema clinical syndrome. The area postrema is an area of the medulla in the brainstem, and it's what contains the chemoreceptor trigger zone. This is what makes people nauseous when they receive chemotherapy. And so when neuromyelitis optica leads to lesions of the area postrema, that causes the patient to develop intractable nausea, vomiting, and hiccups. And this syndrome has been well described as being associated with neuromyelitis optica. The treatment is with steroids, usually intravenous methylprednisolone, and this is the same treatment that's used for exacerbations of multiple sclerosis. And recurrent attacks are treated with immunosuppressants, and this is also somewhat similar to the treatment of recurrent attacks of multiple sclerosis. Our next demyelinating disorder is PML, which stands for progressive multifocal leukoencephalopathy. This is another inflammatory central demyelinating disorder, and PML is caused by reactivation of a latent infection with the JC virus. The JC virus is ubiquitous and many of us are exposed to it. If you are immunocompetent, it will not cause symptoms or infection, but it can become latent inside your body. If you then become immunosuppressed, it can reactivate, and when the JC virus reactivates, that causes PML. The JC virus leads to viral destruction of oligodendrocytes. Those are the cells in the brain that myelinate neurons, so when they are damaged, demyelination occurs. And as I said, this requires immunosuppression. Classically, PML is associated with late-stage HIV. It can also be associated with leukemia and lymphoma, especially in patients who are receiving chemotherapy. And then there is an antibody therapy for multiple sclerosis called natalizumab, which is famous for causing reactivation of the JC virus. And in any patient who is going to be treated with this drug, they need to first be screened for antibodies to the JC virus. PML presents with subacute focal neurologic deficits, and by subacute I mean a relatively slow onset, usually over weeks or months. The deficits can be motor or sensory, and in addition, patients usually develop encephalopathy and symptoms of confusion. You can make the diagnosis with MRI. It will show multifocal lesions with no mass effect. If you look at this MRI on the screen, you can see this large white lesion. Note that it's not producing any mass effect in shifting the midline. That's characteristic of PML. You can also do a lumbar puncture and look for JC virus IgG antibodies in the CSF. The gold standard is a brain biopsy, but this is rarely done. And PML is a progressive disorder. That's why it has the word progressive in the name, and it will ultimately lead to worsening neurofunction unless you resolve the immunosuppression. There is no effective direct therapy. What you need to do is get patients to reconstitute their immune system, and then the PML will go away when the immune system is working. Now let's talk about peripheral demyelinating disorders, and the classic peripheral demyelinating disorder is Guillain-Barré syndrome. This is an acute disorder that comes on rapidly over days. It's an inflammatory demyelinating radiculopathy, meaning it causes dysfunction of peripheral nerves. In Guillain-Barré, Schwann cells are destroyed by the immune system, and the Schwann cells are the myelinating cells of the peripheral nervous system, and that leads to nerve dysfunction, and patients can develop motor and sensory deficits. We'll focus on the most common variant, the acute inflammatory demyelinating polyneuropathy variant. And the classic feature of this form of Guillain-Barré is ascending muscle weakness. It develops over days and weeks, and it's called ascending because it starts in the legs and then spreads upward to involve muscles higher up in the body. In up to a third of patients, it leads to respiratory failure, and patients with Guillain-Barré often end up in the ICU on a ventilator because of respiratory muscle weakness. It also commonly involves the facial muscles as well. Because the peripheral nerves lose their myelination, the deep tendon reflexes won't be normal and they will be lost. That's because these reflexes are a circuit in the peripheral nervous system, and if you don't have myelination, then the reflexes won't be normal. Sensory deficits can also occur. Usually these are paresthesias, but these are mild and not usually the dominant feature. And symptoms usually resolve over weeks to months, but you should know it can take a long time for patients with Guillain-Barré to get better. I saw a patient once who still had muscle weakness and difficulty walking a year after he developed Guillain-Barré. Autonomic dysfunction is also very common in Guillain-Barré syndrome. This can present in a number of different ways related to the sympathetic and parasympathetic nervous system. Patients are often tachycardic, and they can have either hyper or hypotension. Urinary retention is very common. Many patients have difficulty urinating when they have Guillain-Barré syndrome. Arrhythmias can occur, ileus of the bowel can occur, and loss of sweat can also occur. And so Guillain-Barré is a very serious illness, and people can die from it. And the way they die from it is either due to respiratory failure, like I mentioned on the last slide, or severe autonomic dysfunction. They either become markedly hypertensive or hypotensive, and this leads to death. Guillain-Barré is usually triggered by an infection, and the classic agent is Campylobacter jejuni, which causes bloody diarrhea. So in a board question, a patient with Guillain-Barré is going to be described as having had a diarrheal illness a few weeks before the onset of symptoms. Other agents that have been reported to cause Guillain-Barré include cytomegalovirus. CMV is the most common virus associated with Guillain-Barré syndrome, also Epstein-Barr and HIV, and there have been rare cases of Guillain-Barré syndrome being triggered by an immunization. Guillain-Barré is a clinical diagnosis made based on the history and physical exam. But you can find supporting evidence for the diagnosis by doing a lumbar puncture and analyzing the cerebrospinal fluid. The classic finding in Guillain-Barré syndrome is an elevated protein count with a normal cell count. This is called albuminocytologic dissociation. This is a very unusual finding. Normally when the protein count is up, the cell count is also up. Guillain-Barré is unique in causing this finding, referred to as albuminocytologic dissociation, and make sure you know this for your board exams. You can also do nerve conduction studies, which will show abnormal nerve conduction of the peripheral nerves in Guillain-Barré syndrome. And the mnemonic most people use to remember the classic findings in Guillain-Barré are the 3 A's: ascending paralysis, autonomic neuropathy, and albuminocytologic dissociation. Let's talk about the treatment of Guillain-Barré syndrome. First of all, respiratory monitoring and support is critical because the way that many of these patients die is from respiratory failure. In terms of respiratory monitoring, what's usually followed is the vital capacity by spirometry and the negative inspiratory force, which is measured by a NIF monitor. The vital capacity represents how much air the patient can push out of their lungs, and the negative inspiratory force represents the musculature to draw air into the lungs. And initially, when patients are diagnosed with Guillain-Barré, these things are often measured every few hours until the patient is stable. And then if any evidence of respiratory failure develops, the patient needs respiratory support, often with mechanical ventilation. Besides this, patients can be treated with plasmapheresis. This is done via a plasmapheresis machine, like what is shown on the screen here. And what plasmapheresis does is it removes plasma and cells from the body and then returns only the cells. And the idea here is that it will remove harmful antibodies from the patient's plasma. An alternative to plasmapheresis is IVIG, or IV immune globulins. These are pooled antibodies from donors which can be infused into patients, and they have a number of immunosuppressive effects. One of the things they do is they can neutralize antibodies in the patient's plasma so that autoimmune activity will decrease. And then lastly, I just want to point out that steroids are not effective in Guillain-Barré. Make sure you know this and don't choose steroids as an answer in a board question. Our last topic for this video is CIDP, which is chronic inflammatory demyelinating polyneuropathy. This is also a peripheral nerve disorder, and it shares many similarities with Guillain-Barré. You can think of it like a variant of Guillain-Barré. It has motor weakness, it has loss of reflexes, it also has albuminocytologic dissociation. All of these are the same as is found in Guillain-Barré. The main distinguishing feature of CIDP is that it has a different time course from Guillain-Barré, and steroids work in CIDP. In terms of time course, in Guillain-Barré, the time from the onset of symptoms to the maximum weakness is usually 4 weeks or less. Guillain-Barré syndrome is a relatively rapidly progressive disorder. CIDP has the word chronic in its name, and that's because it's a more chronic disorder, and it usually takes at least 8 weeks or longer for the patient's symptoms to reach the point where the muscles are maximally weak. And then in terms of corticosteroids, in Guillain-Barré syndrome, as we've already discussed, there's no benefit to corticosteroids. In CIDP, they are effective. And that concludes our module on demyelinating disorders.